Okay, we're going to do a quick run through the nephron from beginning to end, and this is going to go quick, but it serves as a great review if you are studying kidney physiology. So we're going to start at the level of the glomerulus, and so keep in mind the layers here include a fenestrated endothelium, a glomerular basement membrane, and then podocyte foot processes that have slit diaphragms in between each of these. And so the things that will be filtered across this filtration barrier include water, sodium, potassium, calcium, magnesium, glucose, small solutes, small amino acids, lactic acid, small drugs and toxins, especially things that are water soluble. And so things that are left behind would be large plasma proteins like many immune globulins, albumin, red blood cells, white blood cells. All those types of things will be retained in the capillary loop. Okay, the first segment is the proximal convoluted tubule, and so this is a really important segment because it does lots of tubular reabsorption, and there's lots of tubular transport occurring here. This is a good number to remember, so 2/3 of all the filtered sodium, so 67% of the filtered sodium is going to be reabsorbed in this segment. So how is it being reabsorbed? It's being reabsorbed with a whole multitude of transporters. So think about all the stuff we just filtered. So we just filtered glucose and bicarbonate, phosphate, amino acids, and organic acids. These are things that we really don't want to waste in the urine, and so we reabsorb this here in the proximal tubule through cotransporters. So here we have a sodium glucose cotransporter, so SGLT1 and 2 will reabsorb sodium along with glucose because we don't want to waste glucose in the urine in normal situations. And we also don't want to waste phosphate, amino acids, and organic acids in the urine, so we cotransport it along with sodium. And so this whole system works because we have the sodium potassium ATPase on the basolateral side. This will make sure that sodium concentrations are very low inside the cell. That way there's always a sodium gradient that will favor sodium movement from in the tubular lumen, where sodium is high, right? It's close to plasma at this stage, to very low. So high sodium here, low sodium here, and this will facilitate the movement of sodium. And if we have a specialized cotransporter, it will pull the other thing with it: glucose, phosphate, amino acids, and organic acids. So it's important to note that the proximal tubule is the main location for the reabsorption of these solutes. So once these things pass the proximal tubule, they're going to be spilled into the urine. And of course, that would only occur if the transporters get saturated or there's some sort of dysfunction with the transporter, either pharmacologically or genetically, or if there's some dysfunction with the proximal tubular cell. And then it's also worth noting that there are water channels on the basolateral side and chloride channels, so that as you reabsorb sodium, water will follow and chloride will follow as well. And so essentially, the net effect here is that you're reabsorbing lots of sodium and solute along with water, and then chloride will follow. Next, there's another really important thing that the proximal tubule does. That's the reabsorption of filtered bicarbonate. So bicarbonate is a small molecule. It will be readily filtered through the glomerulus, and so this is something we don't want to waste into the urine. We want to reclaim it. We don't want to lose it because we need to buffer acid on a daily basis. Here's how the proximal tubule does it. There's a sodium proton, right? Sodium hydrogen ion antiporter. Sodium will move into cells. Remember, there's a chemical gradient. A proton is pumped out. And so in the presence of carbonic anhydrase, which is right here, and this is sitting at the brush border of the proximal tubular cell, proton and a bicarbonate will combine to form carbonic acid, and then carbonic anhydrase will facilitate the conversion of that to CO2 and water. So water will move into cells with transporter, and then CO2 will diffuse into cells because it can cross cell membranes. And now, because the cell is being packed with CO2, we have intracellular carbonic anhydrase that can basically perform the reverse reaction. And essentially, the proton here can be recycled, and the net effect is that the bicarbonate can now be transported out on the basolateral side with sodium. So essentially, the net effect is reabsorption of sodium and bicarbonate. So the proximal tubule is doing lots of transport, and because of this, it has a very high demand for energy, right? Because we spend energy to move sodium outside of cells and pump potassium into cells with the sodium-potassium ATPase. Because of the high energy demands, this cell is packed with mitochondria, so it's very sensitive to ischemia, very sensitive to low oxygen delivery, and so tubular cells can undergo necrosis quite easily, maybe a little more easily than other cells in the body. And so the high energy demands mean that this segment is quite sensitive to that and other toxins, because it's also responsible for the tubular secretion of organic acids and drugs. So many of the drugs that we will prescribe patients need to pass through the proximal tubular cell for active secretion, so to be secreted into the urine. And so a lot of these things can interact and cause tubular damage. So this is an important concept. Next, we're going to move to the loop of Henle. So right after the proximal tubule, we move to the loop of Henle. And just for ease of the diagram, this is sort of a more truncated appearance, but imagine this being much, much, much longer. And so here are some important concepts. The interstitium of the cortex of the kidney has a osmolality about 300 milliosms per liter. But look, as you go deeper and deeper down into the kidney towards the medulla, you see that there's a gradient. So 600 milliosms maybe in the middle, and then as you get towards the deepest segments of the medulla, we have a very concentrated interstitium, 1200 milliosms per liter. This is the corticopapillary osmotic gradient. And so this concept allows us to concentrate and dilute our urine. And I'm going to show you how this is done. Number one, the main concept is that this is established by something called countercurrent multiplication in the loop of Henle. And so essentially we have urine flow in this direction, and on the descending limb of the loop of Henle, notice the following. This is permeable to water, so water can leave, but solute cannot. And so what I've done here with the colors, I'm trying to show you that as urine flows down the descending loop of Henle, water will leave and solute remains behind. So as we're doing that, we're concentrating the urine in the tube. So you can see in the loop, we're the most concentrated at the very tip. Now on the ascending limb, the properties are different. So you can see that here we are permeable to solute, but not water. So water cannot cross the cell membranes here. There are tight junctions, but we are actively pumping out sodium and chloride. And essentially the transporter here, jumping ahead a little bit, is the sodium chloride potassium cotransporter. And so we are actively pumping sodium and chloride across the membrane here, but leaving water behind. As we pump solute out but leave water behind, we're essentially diluting the urine in this direction, okay? So we're concentrating urine in this direction, but we're diluting it back up in this direction, okay? And we're not doing this for no reason. We're doing this on purpose to try and generate a corticopapillary osmotic gradient so that later, if we need to, we could reabsorb lots of water during times of water deprivation. So I'm going to jump over to the collecting duct just for a second. And so essentially this mechanism allows us to pack the interstitium with two things. Number one, sodium and chloride. So we're going to pack it with sodium chloride. And then there's also urea recycling that occurs in the collecting duct. There are urea transporters, and so about 50% of the osms in the interstitium come from sodium chloride. The other 50% come from urea. And so this corticopapillary osmotic gradient, right? So 1200 milliosms, 600, and then 300 is isotonic to our plasma. If we need to reabsorb water in the collecting duct, like in times of dehydration or stress where we need more water and maybe don't have access to water, we can place aquaporin channels into the luminal side of the principal cell, and this will allow water to be reabsorbed because water will only move according to osmotic gradients. So if the interstitium is more concentrated, right? It's more concentrated than the tubular lumen, water will move. Therefore, we have to have this be really concentrated and more concentrated than the urine in order for water to move. You want water to move and be reabsorbed during times of dehydration or stress, like if we were out hiking or exposed and didn't have good access to water. So this is a difficult concept, but one thing that helps make sense is understanding how the system is maintained, because you could argue that, well, if sodium is being reabsorbed here, but water is being reabsorbed here, wouldn't they just sort of cancel each other out and keep the interstitium isoosmotic to the urine? So we also have countercurrent exchange with the vasa recta, and so these will help maintain this corticopapillary osmotic gradient that's established by countercurrent multiplication in the tubes. And so the vasa recta, remember, they're traveling in close proximity to the tubules, and so they're able to participate in osmotic exchange. And so water and solute will move according to the interstitium across the vasa recta, so they are permeable, okay? So as the vasa recta descend, they're able to take some of the sodium and solute as well. So they will become concentrated as they head towards the tip, and then as they're ascending, right, next to descending portions of the loop of Henle, if they're concentrated and coming back up, they're ready to take some of this water, okay? And so they're essentially able to take some of the water out of the way, and this will allow the corticopapillary osmotic gradient to stay as high as it remains, okay? And so this is really important because we maintain this all the time. We spend a lot of energy doing this in order to be able to reabsorb water at a moment's notice. And we're not always reabsorbing water. We're only doing it in the presence of a signal, and that signal is antidiuretic hormone. Let's get into more details on the ascending loop of Henle. And so to pay close attention into how solute transport occurs here, here's the major player, the sodium, potassium, chloride cotransporter, where 2 chloride, 1 sodium, and 1 potassium are being packed into the cell. And so all of this is also being driven by sodium-potassium ATPase, which keeps sodium concentrations very low inside the cell. So that sodium driving force is going to pull everything else with it. And so the way I like to think about this is that, look, we're moving a potassium into the cell here. We're moving potassium into the cell here. And so we're really packing potassium into the cell. And, you know, this whole system wouldn't work if there was not a potassium leak channel. Oh, fortunately there is, right? So this is called ROM-K. And so this will allow potassium to leak out of the cell. And so thanks to this will generate a potential difference where the lumen, right, the lumen will be slightly positive and the cell will be slightly negative. And this is because we're packing the cell with potassium, and then that potassium chemical gradient will allow potassium to leak out of the cell, and that will produce a negative potential inside the cell with respect to outside the cell, okay? Now, on the other side, of course, there is a potassium channel, there's a chloride channel, and then we can move potassium and chloride outside the cell if we need to. So the importance of this segment is that 25% of the filtered sodium passes through this transporter, and that's important clinically because with one transporter, we can make a lot of impact on sodium excretion with a drug. And so we do have medicines that block this transporter, and those are called loop diuretics. So a loop diuretic will block reabsorption here, and then we can remove sodium from the body, okay? So this is important, one transporter, one drug, and if a lot of filtered sodium passes through this one transporter in the one cell, that really helps us, okay? So there's one other important concept. Remember how we mentioned there's a positive lumen potential with respect to inside the cell, and this is all established by potassium movement out of the cell. This will also facilitate the paracellular reabsorption of calcium and magnesium. So if the inside of the cell is negative with respect to the outside, that positive lumen potential will help push calcium and magnesium through paracellular channels that allow the reabsorption of both calcium and magnesium. And so this entire setup, basically the net effect, we're reabsorbing sodium and chloride, maybe there's a little bit of potassium, but mainly calcium and magnesium. And so using a loop diuretic, if we shut this down, not only do we waste sodium in the urine, but we waste calcium and magnesium. All right, so just past the thick ascending limb of the loop of Henle, we arrive to the Macula Densa. And so this is a specialized area. And so imagine I'm taking a cross-section of the tubule here, and now we're looking at its relationship to the glomerulus. And so they're right next to each other, and so they're neighbors, essentially. And so this is the tubule, and here's the glomerulus, and here's the afferent arteriole, and here's the efferent arteriole. And so I'll put an E here and an A here. And so this segment is very important clinically. This is a way for the glomerulus and the kidney to kind of double check on itself and make sure it's doing the right thing at the level of GFR. And so autoregulation of GFR is important because our body, our kidney, wants to maintain a stable GFR independent of blood pressure and fluid status. This is one way to verify that. Essentially what the Macula Densa is doing, it's double checking how much sodium and chloride is making its way at this level of the nephron, okay? And so it will take this information and it will adjust the vascular tone of the afferent arteriole at the glomerulus in order to regulate GFR. In other words, this is a sodium sensor, okay? It's a sodium sensor such that if it senses high levels of sodium, right? If it senses high levels of sodium, it makes an assumption, all right? It makes the assumption that, wow, we must have a lot of sodium in our body, our blood pressure must be high, we must have excessive volume in our body. That could cause high GFR. Therefore, I want to regulate the GFR. So if I sense high sodium, then I'm going to cause afferent arteriolar constriction to try and maintain a GFR. Does that make sense? So now let's consider the opposite, right? Let's consider low sodium chloride delivery. And so this could be a situation, here I'm going to mark these out. This is a situation where you are volume depleted. Maybe you've been having excessive diarrhea and you're losing isotonic fluid that contains a lot of salt and water. And so you're losing both of those things. Your blood pressure is low. You feel a little dizzy when you stand up. In that setting, all the hormones will be active to reabsorb sodium and water from the kidney. And so the proximal tubule and the loop of Henle will be reabsorbing as much sodium as possible. Okay, very efficient at reabsorbing sodium to try and restore extracellular fluid volume, restore the blood pressure, and keep you from passing out or dying, right? So if less sodium chloride is going to make it this far to the macula densa, it will sense it. It will sense that signal. And in the setting of low sodium chloride delivery, the response will be to dilate the afferent arteriole, because the GFR wants to remain the same, and then in spite of a lower blood pressure, in order to boost intraglomerular pressures, it'll have to dilate the afferent arteriole. It'll have to open up the inflow to keep GFR the same despite lower blood pressures. So what the kidney is trying to do is to sort of estimate blood pressure based on the delivery of sodium to the macula densa. So I agree, the nephron's making some assumptions here, but this is the best it can do, and this is how it works. These signals sometimes get mixed and crossed in pathologic situations, and that's why this stuff is clinically important. But just think about this in terms of normal physiology. If you are fluid overloaded or have excessive sodium in your body from eating a very salty meal, the afferent arteriole will constrict because it does not want the GFR to be so dependent on blood pressure and fluid status. If you are low in sodium, low sodium delivery will cause afferent arteriolar dilation, and all this is really done to keep the GFR stable despite changes in blood pressure or fluid status. Next, we're in the distal convoluted tubule, and so the DCT and the collecting ducts combined will handle about 8 to 10% of the filtered sodium. So in the distal convoluted tubule, we had this sodium chloride cotransporter, and so we just call this the NCC channel. And so the sodium chloride cotransporter will transport both sodium and chloride in an electroneutral fashion. And this is all being driven by using energy to stimulate or pump the sodium-potassium pumps on the basolateral side. And so you can see we also have a chloride channel on the back end that will allow the chloride to passively move into the basolateral side. This segment is also important because we have some regulated calcium reabsorption that occurs in this segment. Parathyroid hormone will stimulate calcium reabsorption, and this is all mediated by adenylate cyclase. We do have medications that will block the sodium chloride cotransporter, and these are called thiazide diuretics. So the most common ones used are hydrochlorothiazide and chlorthalidone. And so these are first-line therapies for hypertension. And then there's another one called metolazone that we tend to use for fluid overload and edema. So next we're moving to the collecting duct, and this is a really important and busy cell called the principal cell. So first we're going to talk about sodium transport here. This is an epithelial sodium channel, and you can see that only sodium moves through. We call this ENaC, so epithelial sodium channel. And so sodium will move into the cell thanks to that sodium gradient, and you can see this is why we have the gradient, right? So sodium is very low inside the cell, potassium is very high. This will favor the movement of sodium into the cell, but sodium by itself will generate an electrical potential, right? So if sodium were to move into the cell where there's already a lot of potassium, you can imagine that the lumen may become a little more negative compared to inside the cell, which will have a tendency to be a little more positive than it used to be. This all by itself will favor the movement of potassium out of the cell thanks to these potassium leak channels. And so in my mind, the way I think about it, anytime a sodium enters, a potassium is going to leave, okay? So sodium goes in, potassium comes out. The more sodium that passes by here, the more potassium that comes out. And so this cell is very important for potassium secretion. So if we need to get rid of potassium, if we've ingested a very large potassium diet and have a large filtered load of potassium, this is one way we can actively secrete potassium, okay? So this is all under hormonal control. And so aldosterone is a hormone. It's also called a mineralocorticoid. And so you could think about the name mineral. It handles the minerals, and the minerals are sodium and potassium. So aldosterone binds the mineralocorticoid receptor that goes to DNA and induces produces transcription products, new proteins, and essentially the big picture is that it will stimulate the production and activity of ENaC. It will stimulate the sodium-potassium ATPase and stimulate the activity of the ROMK channel, these potassium leak channels. So in the presence of aldosterone, all of these channels will be more active and more present, and the cell will be more energetically active. And so high potassium hyperkalemia will stimulate the production of aldosterone. Okay, so this alone stimulates aldosterone, and also remember, aldosterone is produced as a downstream effect of the renin-angiotensin system. A couple more things that are important to note, and in order to secrete potassium, we need a couple things to occur. Number one, we need sodium to make its way down here. And so the more sodium that arrives to these distal segments, and so the term that is used in books is distal sodium delivery. And so as long as a lot of sodium makes it here, we can sort of run the machinery and stimulate potassium secretion. So the more sodium that arrives at ENaC, the more potassium that gets secreted. This can explain why using loop diuretics or thiazide diuretics will stimulate potassium losses in the urine. Okay, there's also a primary cilia, and that's what this is right here sticking out of the cell. And based on urine flow, so imagine just the mechanical force of urine flowing past the cilia, it will bend it, and it causes calcium influx into the cell, and that will help stimulate the ROMK channel. So in summary, heavy flow rates will stimulate potassium secretion at this segment. High levels of sodium delivery will stimulate potassium secretion at this segment. And then the other way I think about the flow rate, as long as potassium is very low in the urinary lumen, and with a high flow rate, you can imagine there would be rapidly lowering concentrations of potassium passing by here. All those things will stimulate potassium secretion. And then hormonal control through aldosterone will also stimulate potassium secretion. And whether that's due to the plasma potassium being high, which would be appropriate, or whether it's due to the renin-angiotensin system, all those things will drive potassium secretion. So other important things happen at the principal cell, and this is water reabsorption through the action of vasopressin. The other name for this is antidiuretic hormone. So the default setting for the nephron segments from the loop of Henle onward is to be impermeable to water. Okay, so normally water will not be reabsorbed. The default setting is to make a very dilute urine. Okay, even at the level of the distal convoluted tubule, the lumen osm could be as low as 100 milliosms per liter, and we could dilute our urine down to 50 milliosm per liter. That's the default setting. But only in the presence of vasopressin or antidiuretic hormone, now the collecting duct will be permeable to water. And so this is through the action of the V2 receptor, and you can see it's a G protein coupled receptor. Essentially, we have aquaporin channels that are sitting in these vesicles, and they're ready to go. And in the right signal, when vasopressin is present, they will move to the lumen, be inserted into the lumen, and the water channels will now allow water to move and be reabsorbed. And I hope you can remember why the water would even think about moving, right? If there's a lot of water in the urinary space, but the interstitium is concentrated, so thanks to that corticopapillary osmotic gradient, right, as long as the urinary lumen is very dilute, and it should be, remember the default setting is to make dilute urine. Maybe it's around 100 to 50 milliosmoles per liter, but once the aquaporin channels are in place, it looks across the channel, and the interstitium is very concentrated. 600 to 1200 milliosmoles, it's packed full of sodium chloride and urea. Now water will move, water gets reabsorbed, and now you can survive in times of water deprivation. So while we're in this region, I'll just briefly say that the collecting duct is where urea gets reabsorbed, and antidiuretic hormone, or ADH, will stimulate urea reabsorption. And this makes sense because we're trying to pack the interstitium with osms. We want this to be concentrated such that when we need to reabsorb water, it's ready to go. And the only thing that will drive the reabsorption of water is vasopressin or antidiuretic hormone, the same thing. So on the other side, we're going to focus on the acid-base handling in the collecting duct. We have these other cells, the intercalated cells. You can see there's a alpha intercalated cell and a beta intercalated cell. These are essentially mirror images of each other. And so this is the main site where protons or acid is being secreted by the kidney. And so every day we generate non-volatile acid in our body every day. We can't breathe this acid off like we can CO2. This acid has to be actively pumped out and lost in the urine. And so we have a couple of main mechanisms for doing this. Number one, we expend energy for a proton pump to pump protons into the urine. We also have a potassium proton exchanger because we have to spend energy again to move potassium into cells. Remember, in every other segment I've shown, potassium really wants to leave cells, but here we have to use energy to pump it into cells in exchange for a proton. So this is the main site of a couple things. Number one, proton secretion, and also potassium reabsorption. So if we need to reabsorb potassium due to hypokalemia, this is where that would occur. And where did the protons come from, you may ask? Well, it comes from water and CO2. And so we have intracellular carbonic anhydrase. It will split carbonic acid into a proton and bicarbonate, okay? And this is important because the only way to change acid-base balance is that we pump the proton somewhere that goes into the toilet, right? Eventually we're going to pee out that proton. Now we take that bicarbonate and we reabsorb it into the plasma. And this is the only way we can truly affect acid-base balance on a metabolic front, is by putting the proton in one place and getting rid of it and putting the bicarbonate into the plasma, okay? And then, of course, we have some potassium and chloride leak channels on the other end. So this bicarbonate chloride exchanger allows the bicarb to be reabsorbed into the plasma. So every time we pump out a proton, we regenerate the bicarbonate. And so if we're making acid every day and we make about 1 milliequivalent per kilo per day, let's say if we're 70 kilos, we're going to make 70 milliequivalents of protons. We need to regenerate the bicarbonate that was lost by buffering those protons, and we got to pump the proton out into the urine. This is how that occurs. And real quick, remember that all these protons are not free in our urine. They're not free protons that will contribute to the pH. We get around that by having buffers, and so filtered phosphate and ammonia will serve as buffers. They sort of will grab up all the free protons, and so adding a proton to ammonia creates ammonium. And so once ammonium is in the urine, it has this positive charge and it will be stuck there. And so the titratable acids will also grab a proton and be stuck in the urine. And this is important because now it will be lost in the urine and we flush it down the toilet. So that was the alpha intercalated cell and how it handles acid. And so I keep those in my head, just, A, alpha, acid. And so the beta intercalated cell handles base. And so I think of this as literally just the mirror image of the alpha intercalated cell. Look, here we're doing the exact same process with intracellular carbonic anhydrase, splitting CO2 and water to carbonic acid into bicarbonate and a proton. And so we would only use this if we had, you're right, excessive bicarbonate that we need to get rid of. We need to secrete bicarbonate. And so we do this by pumping the proton into our plasma and transporting the bicarbonate into the urinary lumen, and now we flush that down the toilet. And so this is important. Now we can go both ways. We can secrete protons in times of acidosis, and we can secrete bicarbonate in times of an alkalosis. Okay, so this is important, and this is how the kidney can keep us in good acid-base balance. The sort of big picture here is that distal sodium delivery and potassium secretion here all seems to stimulate proton loss in the urine, possibly at the proton-potassium exchanger. And then also, the way I think about it, maybe if I'm delivering lots of sodium here, remember I said that it can make the lumen a little bit negative. Well, maybe that helps promote proton secretion as well. And so in the setting of excessive aldosterone or RAS activation, proton excretion is also increased. So aldosterone also seems to have effect on the amount of protons being pumped out at the proton pump distally. So you can imagine with excessive aldosterone, if you're pumping out too many protons, you can develop a metabolic alkalosis. And that is pretty much the whole nephron start to finish, front to back. And it's pretty easy, right? That's not too hard. Thank you for watching. So my walk through the nephron was inspired by this illustration by Kara Wrights. And so I used her illustration to serve as the sort of backbone for everything you saw. And they described how they use this for teaching medical students renal physiology, and this reference right here. So great work by this team, and I hope this is helping medical students learn renal physiology.